Yes, lymphomas, the diseases of the blood system. What are the main differences in between these diseases? Leukemias are always systemic diseases, and lymphomas are the regional diseases, and lymphomas affect only the regional lymph nodes. Only at the final stage of lymphoma and the terminal stage, we can reveal the markers of the dissemination. One people with the connection. Group 8. Okay. So, and a few words about the leukemias. You see, leukemia is defined as a systemic malignant tumor of the bone marrow, first of all, of blood-forming tissues, and the first proliferation, the clonal proliferation of leukemic cells take place in the bone marrow. Leukemia is characterized by a large increase in the numbers of white blood cells of leukocytes, and the cells can be revealed in the blood circulation. So I can hear noise. Please turn off the microphones, or I will do it myself. Leukemias are classified according to two main principles: histogenesis, or origin of the leukemic cells, and grade of differentiation, of maturation of the cells. In previous semester, we discussed the tumors. You passed a few classes devoted to tumors, and we discussed with you the principles of the classification of tumors. In generally, the principles are the same. Leukemias also can be classified. One student is here, but unfortunately, I will try to allow. Okay. And the principles are the same, except organ specificity. Some types of leukemia, the development of this leukemia, are connected with the radiation exposure. For example, you can see the example of these changes in Japanese population after the exposed of the atomic bomb in Hiroshima. We found the elevation of the leukemia in the population. And some of leukemias are genetically determined. A bit later, I will demonstrate to you the classical chromosome abnormality connected with the myelogenous leukemia. So the next slide shows us the main forms of leukemias. All of these forms we will discuss with you during the exam. You see on this list, you can see acute and chronic most popular variants. And in generally, acute leukemia, the clinical symptoms, the clinical behavior of acute leukemias resembles the malignant tumors. And the clinical behavior of chronic leukemias resembles the benign tumors. They are not so aggressive, and the patients with chronic leukemias usually have long periods of the remission phases, alternating with the progression. And according to histogenesis, leukemias can be classified into the myelogenous and lymphocytic type. It depends, of course, on the origin of the tumor cells. These characteristics of leukemias, you can see here, myelogenous types can be acute and chronic, and lymphocytic types can be also divided into the acute and chronic variant. Please remember, the acute leukemias, myelogenous and lymphocytic, they are very aggressive, and the symptoms of these leukemias in generally are the same. That's why it's not so important for the patient what type of leukemia of blastic cells can be revealed in the circulating blood and in the bone marrow. And chronic leukemia, they have different symptoms. At the second part of the lecture, we will focus on the changes in organs and on the symptoms of these diseases. So, pathogenesis of myeloid leukemia. This is an example of the disturbances in bone marrow and changes of hematopoietic cells. Different factors, chemical factors, radiation or physical factors, some viruses, for example, Epstein-Barr virus. Hope you remember, Burkitt's leukemia is closely connected with the pre-existing Epstein-Barr virus infection. Some unknown factors. They influence on hematopoietic stem cells and the clonal proliferation of the cells due to the disturbances in the bone marrow. If we can reveal more than 20% of the blast cells, immature cells in the bone marrow, we can write the diagnosis acute myeloid leukemia. In chronic myeloid leukemia, morphologists will reveal predominantly mature cells, more or less mature cells, and you see it's a stable disease. And the myelodysplasia, primary myelodysplastic syndrome is another thing. Today we will focus on the acute and chronic leukemias, and maybe during the lecture we'll discuss with you the myelodysplastic syndromes too. And the outcomes of acute and chronic leukemias, of course, are different. A prognosis of the patient with chronic leukemia is good, and acute myeloid leukemia, usually in few months from the beginning of the process, lead to the hematopoietic failure, infiltration of organs by leukemic cells, and of course, to the death of the patient. The next slide illustrates the acute and chronic leukemia, the specific features of these leukemias. You can see the accumulation of blast cells in different organs and in the bone marrow, and presence of immature blast cells is very important marker of the acute leukemia. And the specific features of these blastic cells resemble the cells that can be revealed in the malignant tumor. A bit later, I will show you the photo, the electron micrograph. These blast cells intensely or active proliferate inside the bone marrow, and they supplant the other hematopoietic cells. That's why deficiency of other hematopoietic cells can lead to the rapid death. And why? Deficiency of the immune cells, deficiency of the erythrocytes, of thrombocytes, of course, lead to the very important clinical symptoms. Anemia, you can read the symptoms here. Thrombocytopenia, leading to bleeding and heavy secondary infections. And except that, of course, these leukemic cells, blast cells, can spread through the blood, and the cells can infiltrate the internal organs, different organs. They can form so-known leukemic metastasis, accumulation of leukemic cells in the parenchyma of organs. And in chronic leukemia, morphologists can reveal the mature cells. These mature cells can be revealed inside the bone marrow again and in circulating blood too. And of course, the cells also proliferate inside the bone marrow. Myelogenous leukemia, chronic leukemia, affects granulocytes and monocytes, and chronic lymphocytic leukemia affects lymphocytes. That's why the clinical symptoms of these leukemias are different. In opposite to acute leukemias, I told you earlier, the clinical manifestation of acute myelogenous and acute lymphocytic leukemia is practically the same, and the clinical symptoms are the same too. And today We will start the discussion of the specific features of the leukemias from the acute leukemia. And now I will demonstrate you the changes in the organs in acute leukemia. Acute leukemias very often can be found in the children, especially acute lymphocytic leukemia. And you see, this leukemia is very aggressive, and this leukemia can kill more than 90% of the patients within the first 6 months. And in acute myelogenous leukemia, this is more or less mild. Patients can experience the remission, but the recurrence of the disease is common. So in acute myelogenous leukemia, the doctor can reveal the alternating periods of activation of the disease and the remission of the disease. And acute myelogenous leukemia can be revealed predominantly in adults, in old patients sometimes too. Causes of death of the patients with acute leukemia are hemorrhages in organs, especially in the brain. Please remember, brain hematoma is the most popular cause of death of patients with acute leukemia, and heavy bleeding too. And of course, presence of heavy secondary infections. For example, necrotizing tonsillitis with destruction of the tonsil, of soft tissue of tonsil, and formation of multiple abscesses in the throat. And by the way, this tonsillitis associated with the formation of abscesses finally can lead to sepsis, septicopemia, and severe pneumonias, very often double pneumonias, also can complicate the acute leukemia, and these pneumonias can lead to the empyema, bilateral suppurative pleuritis, and finally to septicopemia too. I hope you remember the appearance of the malignant tumor cells. In previous semester, we showed you this electron micrograph, and the cell in acute myelogenous leukemia in generally has the same characteristics. You see enlarged nucleus, and nucleus to cytoplasm ratio is always increased in this cell. So irregular distribution of the chromatin inside the nucleus, unusual shape of the nucleus, all of these markers we can find only in the atypical malignant cells, in emblastic cells too. This electron micrograph confirms the conception that all of acute leukemias resemble the malignant tumors. We wrote about the changes in organs in acute leukemias. On this photo, you can see severe necrotizing tonsillitis, the child, of course, the throat of child, associated with acute lymphocytic leukemia. I want to ask you, please use your workbooks now. At the end of this semester, you will give the exam. You can ask your friends, please try to make 0 copies. Maybe our print house is opened now. Please try to buy the second part of our workbook. This part is called Diseases of Organ Systems. And now I will discuss with you the main characteristics of the slides and grosses. I will help you with descriptions. We will fill in the legends together. So I want to ask you, please open your workbook and follow me, and we will describe all slides and grosses. So appearance of the tonsils. You can see 2 tonsils in the throat. Size of tonsils, of both tonsils, is enlarged, of course. Color is reddish white, so the inflamed tissue is reddish in color, and the inflamed and necrotized areas are whitish. Surface of these tonsils is ulcerated, surface is rough, and adjacent mucosa is swollen and reddish too because of prominent inflammation. Of course, this severe tonsillitis with destruction of the tissue of tonsil can lead to the formation of the abscesses inside the tonsils in the tonsillar tissue following hematogenous spread of the infection, and I told you earlier, transformation to sepsis, septicopaemia, is possible in this situation. And the next slide illustrates the most popular complication of the acute leukemia. Slide number, if you want, you can write the numbers of the slide. It's helpful for the self-training for the exam. 36, brain in acute myelogenous leukemia. On this photo, we can see the classical changes in the brain. First of all, lakes of blood destroying the brain tissue. Hope you remember, erythrocytes are always orange-red in hematoxylin and eosin staining, except that we can see multiple leukemic cells in between the erythrocytes. The cytoplasm of these cells is dark purple in color, so known leukemic infiltrates. And at the right part of the slide, you can see the contour, the shape of partially preserved vessel. The walls of vessel are partially destroyed and infiltrated by the leukemic cells, and destruction of the walls of this vessel leads to the formation of the hematoma in the brain tissue. And adjacent brain tissue is swollen and edematous. You can see whitish colored round bubbles nearby the glial cells, pericellular edema. And now on the scheme, I will demonstrate you these changes. So in central part, we can see thin walled vessel, infiltration of the vessel wall by the leukemic cells and destroyed part of the vessel, extravasated blood nearby the vessel in the white matter of the brain, and edema, of course, of the adjacent brain tissue, and the adjacent neurons also with markers of pericellular edema and with the degenerative changes. And now the description. Point number 1 is here. Area of extravasated blood. And on the photo, in central part of the photo, you can see this extravasated erythrocytes, extravasated blood. Point number 2, destroyed vessel wall. You can see on the scheme the destroyed wall, and here too. Only here we can see two parts of the vessel, preserved parts, and at the top of the vessel walls are destroyed. So leukemic cell infiltrate into the brain tissue. On the scheme, leukemic cells are located nearby the vessel, and on photo 2, in area of hematoma and nearby the vessel, we can see multiple leukemic cells. They are dark purple in color because all of these cells, they have large nuclei and small thin rim of cytoplasm. Blastic cells are immature cells. That's why under the light microscopy in hematoxylin and eosin, we can see very large purple colored round leukemic cells. Leukemic cell infiltrate inside the vessel wall. You see the walls of vessels are infiltrated by the leukemic cells, and on the photo 2. It was point number 4. And point number 5, edema of the brain tissue, accumulation of transudate of watery fluid nearby the glial cells. Edema is a complication of this hematoma, and progressive brain edema finally leads to the compression of the brain tissue to the brain coma and death of the patient. So what is the cause of this brain hematoma? Please look at the scheme again. Infiltration of the vessel wall by the leukemic cells and destruction of the vessel wall from one hand, and prominent thrombocytopenia from the other hand. Please remember, two these causes lead to the bleedings and extravasation of the blood to development of hematomas in different organs, infiltration of vessel walls by leukemic cells, and the thrombocytopenia. And now we will discuss the specific features of the chronic leukemias. Chronic leukemias can be revealed predominantly in adults, in adult patient. And I told you earlier, these leukemias are characterized by the protracted course. In these leukemias, doctors very often will reveal the alternation of periods of activation of the disease and remission phases. Chronic myelogenous leukemia very often can be revealed in the adults after the 40s. And this leukemia is characterized by the presence of long silent period before the activation of the disease and before of clinical symptoms such as weight loss, fever, weakness. That's why very often these patients was diagnosed with leukemia after the activation of the disease and after the active proliferation of the leukemic cells in bone marrow. Of course, the untreated chronic myelogenous leukemia can kill the patients because of development of the blast crisis. Blast crisis is very interesting period of the disease, activation of the disease. During the blast crisis, multiple blast immature cells can be revealed in the bone marrow and sometimes in the circulating blood too. And of course, this activation of chronic leukemia, blast crisis, in generally lead to the transformation of this chronic disease into the acute one. And during the blast crisis, in 10 minutes, we will restart the conference. We will relog because so. And the transformation of chronic leukemia into the acute one will kill the patient, and we will see the most popular complications like hematomas, bleedings, and secondary infections development. And the chronic lymphocytic leukemia usually occurs in old people, and also it can be inactive for months and sometimes for years. And this leukemia is characterized by the involvement of the lymph nodes. But in opposite to lymphoma, multiple groups of lymph nodes are usually involved in this leukemia. For example, mediastinal lymph nodes and abdominal lymph nodes, pelvic lymph nodes, lot of groups. And now I will demonstrate you the specific features of chronic myelogenous leukemia. And first of all, so-known Philadelphia chromosome. Philadelphia chromosome is characterized by the translocation between chromosome 9 and 22. And specific features of this chromosome is the elongation of the chromosome number 9 and shortening of chromosome number 22. This genetic abnormality can be revealed more than in 90% of the patients with the chronic myelogenous leukemia. We can say that this disease is genetically determined. And now we will focus on the appearance of the organs and bone marrow in chronic myelogenous leukemia. In your workbook, you can see the description of the spleen, liver, and of the diaphyseal and epiphyseal bone marrow. In general, the appearance all of these organs is the same. The bone marrow and the parenchyma of spleen and liver always have so known pyogenic appearance. They are greenish brown in color. The changing in the color of organ is associated with the infiltration of bone marrow and of the parenchyma of these organs by the leukemic cells. And now the descriptions of organs. Spleen. You can see on photo the spleen, by the way. Size of the spleen is enlarged. Surface is smooth. Cut surface is greenish brown in color. If you want, you can describe the figurative name of this organ. Pyogenic appearance, from word pus, pyogenic appearance. A capsule is tense, and sometimes in this organ, they can reveal the infarcts. In our case, infarct is located in the middle part of the spleen, and infarct is whitish of the color. Sometimes infarcts are absent. Liver has the same characteristics. Size of the liver is enlarged too, and surface is smooth, and cut surface is greenish brown in color. Please remember, in myelogenous leukemia, the enlargement of the organ is very prominent. So in extreme instances, spleen can weigh about 1 kilogram, and liver, the mass of liver can be about 6 kilograms. And diaphyseal and epiphyseal bone marrow of a femur is also greenish brown in color. The same pyogenic appearance of the bone marrow can be revealed. So please describe in your workbook the appearance of the organs, and we will continue. I will demonstrate you the photo of the slide 35A. So by the way, both of these slides, slide 36 and this slide 35A and B, they're included into the exam cards, and during the exam we will discuss these changes. So, liver in chronic myelogenous leukemia. Please pay attention on the location of the leukemic cells. You see, under the high magnification, these leukemic cells can be revealed inside the sinusoids of the liver, and adjacent hepatocytes of the hepatic cords, contain these multiple whitish colored bubbles, fat, in their cytoplasm. Fatty changes of hepatocytes are also visible on this photo. What is the reason for these fatty changes for steatosis? Of course, deep anemia associated with all types of leukemia. On the scheme, you can see the sinusoids in between the cords of the liver, and the sinusoids are infiltrated by the leukemic cells. Portal tract is free of leukemic cells, it's intact. And in cytoplasm of the hepatocytes, we can see these whitish colored round bubbles. We can see the steatosis of hepatocytes. And the legends, point number 1, leukemic cells inside the sinusoids. And point number 2, steatosis of the hepatocytes. The next variant of leukemia, of chronic leukemia, is called chronic lymphocytic leukemia. I told you earlier, the lymph nodes are always affected in this disease. The liver and the spleen too, of course. In all types of leukemia, we can reveal the enlargement of the spleen and the liver. And in chronic lymphocytic leukemia, lymph nodes are always affected. They're also enlarged. And on this photo, you can see the group of mediastinal lymph nodes. They're significantly enlarged, round to oval, and grossly, on the palpation, this conglomerate of lymph nodes resembles the oranges in the plastic bag. It's the figurative name of these lymph nodes. So, description: size of the lymph nodes is enlarged. If you want, you can add a form. Form is round to oval. Consistency of the lymph nodes is soft. They are partially fused. They form conglomerate into the mediastinum, and the figurative name of these lymph nodes is oranges in plastic bag. And now, few words about the liver. During the exam, we will ask you about the comparison between the liver in chronic lymphocytic and myelocytic leukemia. On previous slide, liver in chronic myelogenous leukemia, I showed you the location of leukemic cells inside the lumens of sinusoids, and in chronic lymphocytic leukemia, on this photo, you can see it very well, these leukemic cells accumulated only inside the portal tracts, and the adjacent cells, the adjacent sinusoids, are intact. So focal infiltration of the portal tract is a marker of lymphocytic leukemia. And description of the slide 35b. Point number one, leukemic cells inside the portal tracts. Here we can see the leukemic cells nearby the portal tract, and sinusoids in between the hepatic course are free of the leukemic cells. And of course, we can reveal the steatosis of the hepatocytes again. In 1 minute, we will stop the conference because our time is out. And please, I want to ask you immediately relog. We will continue. I will prepare the new conference for you immediately. So, and on the photo, yes, I didn't show you, accumulation of cells in portal tract, and you see whitish colored areas in the cytoplasm of hepatocytes, steatosis, and of course sinusoids in between the cells are free of the leukemic cells. So, and it seems to me we will wait, and after we restart, I will discuss with you the multiple myeloma. Less than 1 minute, it seems to me in few seconds, the conference will be out.